Okay, you don't have to get too close. Everybody awake? You know how you can tell who the real Dodger fans are? It's the person sitting next to you who's putting his head on the table going to sleep because we were all up till midnight waiting for Freddie to get it done. Great game. Maybe one of the best games ever. So welcome. This is our criminal justice breakout session. I've got 4 distinguished folks with me today who are nice enough to come and give it their time. We have Dr. Emily Wood, who's one of the finest psychiatrists I've ever met. She has also worked in the jail, but currently not working in the jail and in private practice and for different organizations. But she has a wonderful way of speaking about treatment and in ways that mere mortals like us can understand. We have Joann Hubbell, LCSW, who's head of social workers at the jail. So she'll be talking about the role of a social worker and how you may or may not be able to interact with that person. How you can, this is all about advocating for somebody you love with a mental illness who's incarcerated. What do we do? Okay, we also have Dr. Gerald Dr. Gerald Farrell, who is medical director for patient reentry management, and Lisa Powell, who also works with him in patient management. Do you guys want to do more formal introductions of yourself as to your backgrounds or anything before we get started? Button up.
Can you hear me? Okay, there we go. So yes, as Mark said, Lisa and I are in charge of our team called Patient Reentry Care Management. So we have a large team, about 100 or so staff who do all of the release planning for people in the LA County jails. So all 4 jails, the women's jail, the men's central jail, Twin Towers, and our other jail up north, Pitches Detention Center. So any release planning needs, whether that's plugging them into mental health care, substance use disorder treatment, housing, you name it, any release planning needs they have, our team helps take care of those things.
There we are. So I thought before we get into sort of navigating the jail system and how all that works, we'd start with Dr. Wood. One of the things that she said to me a long, long time ago, I'm going to steal your line, Emily, that just made a really huge impression on me is it's really hard to engage someone in treatment through a steel door and a cloudy window in a jail cell. It's tough. So, Dr. Wood, can you summarize a little bit the challenges of somebody who's justice involved, was incarcerated in our jail system, let's say for Twin Towers for right now, in resolving the challenges of treatment engagement in a jail setting?
I will do my best. So I'm going to start by saying 2 things. One is that you're welcome because I went to bed just 3 minutes before the final home run was hit last night. So I'm sure they were like, great, she's in bed. We can finish now. Also, I think I'm providing more color commentation today. These guys are the play-by-play. They really know what's happening at the jail. I haven't worked there for a little over a year. But I do work in advocacy because the patients at the jail are the people who I care about very deeply. And I really feel for their families. A thing that has been very powerful for me to learn is that for many people, for many family members of people with serious mental illness who are struggling, when they actually find out that their family member is in the jail, is in Twin Towers, which is one of the largest mental health facilities in the world, they're actually relieved. I know what it's like in that place. And so that's really scary, right? That families are in a situation where it's actually a relief for their family member to be in jail. So I just want to like really acknowledge that the situation that you're in and the individuals who are in these situations are going through something that's intense and life-changing. The jail in and of itself is a traumatizing place. If you have serious mental illness, you are generally put in a cell by yourself for some period of time, whether or not that's just sort of at the beginning where when we're getting to know you and understand, which level, which P you should be given, or sometimes for longer periods. The people, the mental health providers who work at the jail are trained and know a lot about what's going on there, but the people who run the jail are not mental health providers. They are the LA County Sheriff's Department, and their understanding of behaviors that are related to serious mental illness, what we might call, I don't know, what do you call it? Unserious mental illness. Their understanding is limited. And so it creates a lot of barriers to care. So it's very common for a psychiatrist to meet someone, really having to talk to them, as Mark said, through a steel door. That can be how we have to connect and try to understand what state of maybe psychosis or mania they're in, what medications they might be willing to take or have taken in the past. It's really common that like we're not even allowed to have a person out of their cell when we need to talk to them if the sheriffs deem that that's not acceptable at that time. So it's really a struggle to be able to engage people. What we have going for us is that it's one of the most coercive situations that is imaginable. So for many of you guys who have family members who don't take their meds, I also understand the sort of feeling of like this is the only time when they sometimes do get some meds, because there are situations where we can, be more encouraging about them taking their meds, right? So I think that that's something that is, I'm just sort of pointing out, like I really see how hard it is to be in this situation where you're thinking about your family member. Is it better for them to be on the street free, or is it better for them to be in the jail where maybe they're getting some treatment? And the point is, I don't have a full answer for you, but it is a really hard place to engage people in treatment that they're going to want to stick with for years. And so we remain in a situation where obviously the goal is not to have people with serious mental illness getting most of their care in the jail. I think that's really all I'll say for now, and I'm hopeful that you guys will have questions later.
Thank you. So, treatment delivery in the jail setting compared to working in the community is night and day. Totally, for their doctor, it's a totally different, completely different exercise. What about for the patient? From the patient's point of view, you mentioned trauma and things that they're going through. How do you be able to relieve that anxiety so maybe they'll talk with you? Because there's no private spaces to talk to your patient in a jail.
Yeah, there are no private spaces. You can make things more private, but I think the ways that you it's really the obvious ways that you build rapport with people. You see them, you meet them where they're at. You recognize the humanity in them. You figure out a way to get them out of their cell when that really is what they need. You figure out a way to get them a shower. You do the things that are really the most basic human things, and then you go from there. I mean, the littlest things that were difficult, like I started making a table that had pictures of all the like the most common drugs that I used with like the manufacturer's version that we got at, for the most part, at Twin Towers, because I would have patients who would say, I would ask them about side effects, and they would be like, well, I think the yellow round one makes me feel like this, but the white one is okay. And I was like, oh my God, what do I do with this, right? And in the community, you take them out of the bottles yourself, and that it's still common for people to not fully understand what their meds are doing in the community. But that sort of level of like the number of steps between, me prescribing them, the nurse putting them into the little cups, the nurse giving them out, the wide variety and sort of interaction between the nurses on some floors who will really work with the patients, to encourage them to take meds that they know will be helpful to them, ask questions, will contact the psychiatrist when they're worried about someone, and other nurses who just, they have a lot of pill call. They have a lot of pills to deliver, and they don't necessarily have time for that. So those are just sort of an example of like the way it can be so hard at every step, basically.
And as a doctor, is it really different? I don't know if you've ever worked in CRDF at the women's jail. I would imagine the same things would apply. It's still a pod.
Yep.
So Joan Hubbell is the head social worker. She's an LCSW. Joan, can you, number one, tell us what sort of the job description of a social worker in the jail system is, and what you do, to advocate for your patients there?
I was told, okay, it's working. Good morning. So first, I just want to say that, we're all very aware of how scary it would be to have a loved one in jail. Many of us have had our own family members incarcerated, and all of the managers, there's 5 different program managers of the different mental health facilities, CRDF, Towers, CJ, North. And all of them report directly to me, and we all, our number one criteria when we're hiring people, it's psychologists and social workers, is compassion and someone who sees themselves as an advocate. So I just want you to know that doesn't take away the fear factor and the horrible realities that Emily was just talking about. But I do want you to know that we really do care. When someone comes in, they come in through the intake reception center, and every single person who comes in is seen by a nurse. And then that nurse both asks them if they have symptoms or if they have a history, and they look and see if they've ever been with us before in mental health treatment. And then they determine if they do, if any of those things are true, then they get an assessment by either a social worker, psychologist, or psychiatrist. And that's where their first initial determination is made of what level of care do they need? Are they someone who really couldn't function in a dorm and they're in the high observation, which is what Dr. Wood was talking about and describing, or are they someone who can function in a dorm but couldn't function in the general population? That's our next level, or someone who maybe needs medication but is fine to be in a dorm, and that would be our lowest level of care. So depending on where you work as a social worker or a psychologist, you either are doing those intake assessments, or you might be, if you're in mental health housing in any of our locations, then you are assigned a clinician who follows you, a psychiatrist. If you're in high observation, which is the highest level of care, then you also, we have group like medical caseworkers and psychology interns and some different, a lot of different disciplines who offer groups to those individuals. Depending, if you're in high observation, you're seen once a week by a clinician. So depending on your level of care, it's really going to guide what the interaction is. Like we would love to be doing really intensive treatment to so many people. We don't have the staff for it. So a lot of what we do is just try to make sure like we're keeping you stable and safe. If you're in general population, then we are responding more like if a family member calls, if an attorney calls, if the client fills out a health service request form, we respond to those, or a deputy says, hey, I'm worried about this guy. We also do row walks to see how people are doing. So I just kind of threw a lot of information out, but that's the basic role of the clinicians.
Does there we go. Does each inmate get assigned a particular social worker, or is it a crew that sort of handles a pod or a floor?
If you are in mental health housing, so that would be either high observation, the P3 level, the highest level of care, or if you're in one of our mental health dorms, which is a P2, then yes, you are assigned a person that follows up with you.
The dorms are at pitches, or
there's now everywhere. They're in CJ, they're up north at NCCFM, they're in Towers, and of course at CRDF.
I don't know when that happened, but that's different. So, Dr. Frau and Lisa, tell us about the transition back to the community. You know, some people seem to get discharge planning, other people maybe don't get discharge planning. And who does and who doesn't get, how it works. And, let's start with that sort of your job descriptions, what you do at a certain point in time. You must get notified who's getting out on a certain day. How does it all work? And I'll let you decide what topics you want to talk about.
All right, I'll try to pick up kind of where Joan left off. So she mentioned that during the intake process, there's a mental health. Everyone goes through mental health screening. So and she supervises a large group of social workers and psychologists. So Lisa and I also supervise a large group of social workers, but instead of actually providing treatment or doing group therapy, our social workers actually function more as case managers, and they do all of the release planning services. So anyone during that intake process who is identified as having serious mental illness gets a referral to us. So we don't service every single inmate that comes through the jail. I'd say roughly every month we release from the LA County jail system roughly 4,000 to 5,000 inmates. And those who don't have any mental health issues, we don't routinely get involved in their release planning. But anyone with serious mental illness, we are pretty intimately involved in their case management. And I think Mark brought up one of our biggest challenges is that the release date is a moving target, right? So if we know someone's going to be in jail for 3 months, then we know, okay, we have 3 months to come up with a plan for this person who told us that they were needed assistance with housing or needed assistance with substance use disorder, in addition to their mental health needs. But if there's a large percentage of the clients that we serve who they go to court one day and they've only been in jail for a week and they get released unexpectedly, and we had no idea. We didn't have time to formulate a well thought out plan for them, and that's one of the biggest challenges I would say that we face. But those who we do have a little more time with, I think we're able to actually make linkages to treatment programs outside of here. And I'll let Lisa fill in any other, if there's anything else you'd like to add.
So I just want to start by saying, despite the environment of the jail, there are a number of individuals, Joan's program, our program, of people who care and people who want to help. So just know that there are people there to help inside. We do get the referrals from the intake, And then once we get that referral, we will make contact with someone within the first 10 days of admittance there. And what we do is we go over a really brief, what we call an individualized release plan, where we give them resources to the community that they plan to return to. We get that into their property, and this is a way for them to have some resources just in case they're unexpectedly released, like what Dr. Farrell was talking about. After that, we kind of coordinate with courts. We work with the Department of Mental Health. We work with the Public Defender's Office, and we try and create a plan to meet this moving target. We're not successful all the time, but we are there trying. We are trying to give resources. And then we also have what we call an exit window that's on the outside of custody. Should someone get released and they do want services and they've decided, yes, I do want to go to that shelter that person talked about, they could go to that window and we could help link them there. So we do have services. We do make some contacts, but like Dr. Farrell said, our barrier is that moving target of a release date and the number of individuals and entities involved in the individual's case. And sometimes things are happening we're not aware of.
So I'm curious about the linkage. So some people might need SUD, substance use disorder services, or co-occurrent or mental health services through DMH. Back in the old days, 20 years ago for me, we used to fight just to get a medication prescript that somebody could take to a pharmacy when they were discharged. And what we didn't know is only DMH approved pharmacies would accept it. And people couldn't get meds in the community. And then they started giving some meds, I think. So what is that, is linkage merely, okay, here's a phone number and an address, show up to get mental health, or is there a warmer handoff? Or does it all depend on whether somebody's a P2 or a P3 or a P4? Well, obviously it wouldn't be a P4, but it'd be, how direct is that linkage?
So it varies depending on our, if we know that the individual is being released. So it starts off with the resources. We give everyone DMH clinic information with walk-in hours. So should they get released before we establish that appointment, they can go there. Best case scenario, we have our medical caseworkers meeting with them. We know their release date. We're contacting the DMH clinic and getting that appointment. In order to get that appointment, we need to have a release date for them. But we've been working with DMH. They're very good at working with us and giving us that appointment, as long as we can tell them, yes, this is when the individual is leaving. And then also, I just wanted to mention our release planning teams have a social worker, medical caseworkers, community health workers, nurse. We have a nurse for our program, and then we have substance use disorder counselors. So every person on our team will touch an individual who's referred to us to offer services, to engage with them and see if they're interested in any post-release service.
You also asked about medication. So everyone who our release planning team touches, we have a policy that if they are on medication, particularly medication for mental health diagnoses, that we have a release pharmacy at the jail. So instead of, I guess, 20 years ago, they had to send the prescriptions to a DMH pharmacy, we now have a pharmacy on site at the jail that prepares the medications and actually dispenses ideally a 30-day supply, but at the very least a 14-day supply of medication, which should be in most cases enough to bridge the patient until they're able to follow up with their psychiatrist. And it is, as Dr. Wood pointed out, for a lot of things in the jails, we are kind of dependent upon the sheriff's department to help us with some of these things. So there is a deputy who is assigned to the release area who is supposed to escort every single person who's released from jail to this pharmacy window at the time of release to check to say, okay, did this person have any active medications that they were on while they were here? And if so, pharmacy, can you please prepare them, to dispense at the time of release? So that is something that's I think a little different than it was before, and is definitely a positive.
So I'm a family member. I find out my son's in jail. I don't know who to call. There's a number on the sheriff website, which they're happy for me to call and stay on hold for an hour. I want to advocate because maybe they put my son on the wrong medication, or I want to talk to a social worker because there's things going on and he's real upset. Maybe he's being bullied, or maybe, or I want to talk to the psychiatrist on the floor because he's not taking the right meds. I throw this out to all of you. How do families get inside? How do we make the right phone call? So we now have the correct number, because where did I put that?
Yes, the medical command center
Right.
is staffed by nursing and not at 24 hours. And so they know for each program, they can look up and see where your family member is and then connect the information or request to speak to someone with the right people. If I had, my suggestion would be that the minute that you know that someone's in jail, that you call that number and you provide any information about their diagnosis, the medication they're on, or anything you'd like us to know, and they will share that information right away. And like the psychiatrist, clinician, whomever it might be, they definitely can talk to you and receive any information without a release of information. They can't tell you anything. Like usually you get a call and then they might go visit your family member and say, can you please give me permission to talk to your family? So they can't provide any information without their permission, but they can receive information from you.
So for those of you who don't know what a release of information, it's a HIPAA waiver. Just like if you're in a hospital, they won't talk to the family unless the patient signs and says it's okay to talk to mom or dad or whoever and signs a release. So a lot of questions I get sometimes is, okay, I'm on the phone. My son calls me from jail and I encourage him to sign an ROI, a release of information, so I can be included at least somewhat in what's going on. Who gives them the ROI form? Who should the inmate ask for that release of information form? Sheriff deputies or somebody in healthcare?
It would be the clinicians.
Clinician.
Yeah.
Okay.
And honestly, like because of the environment, they take a lot of verbal, like sometimes they can't have a pencil if they're in HOH. So they just, if they verbally give an okay, then that's what we use.
Okay. So, and then doctors would talk to the family about what medication they're on, and there is an inmate medication information form on the sheriff's website in both English and Spanish, which is your ability as families to let all of them know who the treating psychiatrist in the community was in case a doctor in the jail wanted to call out. That never used to happen. Doesn't happen a lot, but it can happen because you're providing the information. And I had that form developed, actually developed myself when my son was arrested. That's how I got started in all this. I couldn't get a doctor on the phone. And I called for 5 days and I couldn't get a doctor on the phone till I was screaming and yelling and threatening people. And through NAMI, I was in my family class. This is in early 2003. We met with Commander Klugman at the time, who was a big supporter and head of custody. And we were able to get a fax number. So you could fax in that form and it would go upstairs to the clinicians. And by the way, I forgot to introduce myself. So my name is Mark Gale, and I'm Criminal Justice Chair for NAMI GLAC. And I'll share with you a family story for those of you who are have families. And when there is so much stress in the jail, especially if you're experiencing symptoms and really having a rough time of things or psychotic. And I used to go visit. Back then, you just stand in line for 2 or 3 hours to get in. It's different today. And so I'd drive an hour, stand in line for 2 hours, and I'd get in. And I'd go up to the 6th floor or 5th floor, wherever he was, and he would come out and we'd be talking on the phone with the glass window, and he would scream at me for 20 minutes. And the first time he did it, I got really mad because I felt insulted. And I said, "That's it." And I slammed down the phone, bam, and I walked out. And then I went, "Wait a minute. Who's the grown-up here?" And I suddenly realized the level of stress and that he needed a safety valve. He had to let out some pressure. So if he yells at custody, that's not good. He'd end up in a hole or end up in trouble, maybe getting hit. If he yelled at an inmate in his pod, he'd probably get the living you-know-what kicked out of him. The only person there who is safe was me. He knew that if he yelled at me, I'd still come back next week to visit him because he knows I love him and I wasn't going anywhere. So when I went back for future visits, I would go and just let him go off. 15, 20 minutes, ranting, raving, screaming, and then he'd exhaust himself and we'd have a really nice final 10 minutes of our meeting. I share that story with you to don't do what I did the first time. Okay. Be cognizant of the level of stress they're under when they're inside and have some compassion about it. Even though sometimes it's really hard to do because they can be, very abrasive when that occurs. But little story I learned, it's true story. By the way, the correct number for the medical command center. So I've been giving out the men's jail mental health number and women's jail mental health numbers for a long time. Apparently now it's consolidated. This is how you learn stuff. 213-893-5543. And this would be for physical mental health as well as mental health. So anything to do with healthcare. You call the Medical Command Center. I'm sure this is on the sheriff's website too. 213-893-5543. And there is a guide that myself and Jim Randall and Carla Jacobs wrote 20 years ago and was updated in 2015 called "My Family Member's Been Arrested. What Do I Do?" Many of you have seen it. It's buried. I got to talk to Assistant Sheriff Paula Tokar because it's hard to find. I mean, I couldn't find it. And one of our colleagues found it and sent me a link. So it used to be really easy to find. We're going to fix that. And we're going to get these numbers fixed and the stuff we're handing out. What have I left out? What are some important things?
One point just to the psychiatry piece. What Joan said is absolutely right. The best person to talk to is the clinician and what we mean by that is the psychologist or social worker who is like assigned to that person. And then just as those people, for instance, the ones in the HOH setting who are seen by their clinicians weekly, they are supposed to be seen by their psychiatrists at least monthly. So that just gives you a sense of, how many, like the psychiatrists carry a much bigger load. Whereas there might be 4 people on a full pod, a psychiatrist will have 2, like that. They're covering what 8 people might cover in terms of the mental health clinicians. So I do encourage you to, be really kind to the clinician. They will communicate with us, and the psychiatrists, and I'm not there, but the psychiatrists can't always call you back. But if you really do give good information to that clinician, like they are truly putting it in an email and sending it to the psychiatrist. So I think that is the best way to do that. And if the psychiatrist has a question, obviously if there's a callback number, that's helpful, but they can't always sort of get to everyone.
But if they wanted to access someone, whether it be the social worker or a psychiatrist, it's the medical command center number is where to go.
And almost certainly they wouldn't get directly to the psychiatrist. The clinician would be the first one, and then the clinician would reach out to us.
Right. And can we give some so we're using a lot of acronyms, okay? P4s, P3s, P2s, high observation, moderate observation. Would one of you, I can do it, but I think you'll do a better job. Explain the difference between a P4, 3, 2, and a 1, and what high observation and moderate observation housing is. And general population, what in plain English?
Sure. So P4 is someone who needs inpatient hospitalization. And we do have a 35 bed inpatient unit and then a smaller unit that you know very well, Dr. Wood. So anyone who needs hospitalization, they are P4. P3 is someone who is pretty ill, like really struggling. We feel like they might be victimized or wouldn't be able to follow instructions in a dorm. And so they are called high observation. They're either in a single cell by themselves or in a double man cell with someone else who's P3. So the P3, P4 kind of lines up with high observation. And then P2 is someone who maybe they have anxiety, depression, maybe they have a more serious diagnosis, but they're on medication and they're stabilized. And we don't worry about them functioning or being victimized in a dorm. That would be the P2 level of care. And that goes along with moderate observation housing. Those are the sheriff's terms, the high observation, the moderate observation. So moderate observation, think of a dorm, and those dorms are in every facility now. It used to be only in towers. Now they're everywhere because the population continues to grow. And then the final level, the lowest level of care would be P1. And that is someone who can manage in general population, meaning you have no special classification. You're with everybody else, but you are on medication. And so you're going to be followed by a psychiatrist every 90 days.
And to give you an idea how bad things are, is 23 years ago when my son was there, the mental illness population was maybe 4 or 5 floors in one tower. Okay. And now all of Tower 1 and all of Tower 2 are high observation housing. Correct me if I'm wrong. And then, and that would be the P3 designation, people who are still very, very ill, but they don't need an LPS designated acute care level of treatment. So it's just below that. And then the P2s, who are moderate observation housing, are they all at Pitches Detention Center now in Men's Central?
Yeah. Okay. There's a few of those dorms left in towers. There are a number of dorms at MCJ.
Right.
And then also in North at Pitches. Yeah.
So 44% of the men in jail have, the last figures I saw, have serious mental illness. 66% of the women in CRDF have serious mental illness. So the system is failing our folks tremendously, where we now have so many people. There's over 7,000 people with mental illness in the jail system at all the different locations, out of about 13,500, I think, total. So the numbers are going the wrong way. And that's why NAMI GLAC's been struggling and working so hard, meeting with our supervisors and their staff, with the sheriff, to try to find alternatives. Personally, it's time for the mentally ill to get out of cells in Twin Towers and be placed where they belong, which is in a therapeutic environment. And that is our policy, and we're sticking to it. And it's not particularly popular in a lot of circles in the county, but people can't get well in a cell. We've all heard that phrase. And I'm done waiting. So is NAMI GLAC. So we are meeting with the sheriff. We have embraced an idea of some kind of care campus. No one knows what that's going to look like. My original idea got shot down already. But I don't know how to build a care campus or a therapeutic or a clinical setting. But we need people in therapeutic environments. And that you're going to hear that discussion in the county probably a lot over the next year or two, until the community safety implementation team, which used to be called the jail closure implementation team, comes up with a plan. And right now they're writing a plan to try to close Men's Central without building anything new. We've been very clear. We were at the Board of Supervisors hearing last week, and we told them it won't work. And what we need to build are places appropriate for people who are ill, who can receive treatment. So when they get discharged, they're healthy and stabilized on their medication and not coming out of a jail cell. And the only way to ever close Men's Central Jail, as far as NAMI GLAC is concerned, is we've got to move people with mental illness out of the towers into therapeutic environments. That means new construction, new facilities. So the people who don't have mental illness, who are serving time in Men's Central Jail, can then be moved across the street to the towers, which was what it was originally built for, a maximum security jail. It wasn't built to be a mental health facility. That's our policy. And by the way, we have an advocacy committee and a criminal justice committee, which we've now combined. Paul Stansberry runs our advocacy committee. Thank you, Paul. And I run our criminal justice committee. And the first Wednesday of every month at 5 o'clock, we send out our links and our invites. And we talk more about these things from an advocacy policy perspective on those Zoom meetings. So please join us and we can get into that in more detail. What have I left out anything? Questions? Anybody have a question? Go ahead.
LA County through MHOS, Mental Health Advocacy Services, for a small nonprofit in LA. I realized that the scope, or my question may be slightly above or beyond the scope of today's presentation. But I also know that Mark, if I may share stories. So I have a question really. My grandma was recently put on a non-carceral setting. And so my question is, what happens when a family member refuses to follow doctor's advice or the recommendations of psychiatrists? She was discharged on Friday, and again, against the wishes of psychiatrists. So that's my question.
This is an LPS law question. So you're saying she was in a non-carceral facility on a 5150, and you're asking about her taking medications?
Correct. So my mom is her primary care, sort of like primary caregiver, and she was on heavy medication. She's 95. My grandmother. She was on 2 different really heavy medications. She's been recently been taken off of them, and so she's having withdrawals, in my opinion. Heavy withdrawals, and so she's been hospitalized twice this month. And again, her most recent hospitalization was a week ago.
Yeah, I mean, I'm happy to talk to you afterwards as well, because I think this might just be an LPS, not just, but I mean, the proper chain of events is that she's put on a 5150. If at the end of the 72-hour hold, the treatment team says that this person is still a danger to themselves, others, or gravely disabled, and they don't feel that they can be safe in the community, then they put them on a 5250 hold. And if the person is refusing medicines that the team believes would help them be not a danger to self, not a danger to others, or not gravely disabled, then they file for a Reese petition, and the Reese petition has to be granted by the judge in order for medications to be given involuntarily in the LPS setting.
Okay, perfect. Thank you so much.
So just to follow up, so that's sort of what happens in the community. So the rules are a little different, I think, in a jail. I mean, if somebody refuses medication in the jail, there would need to be a psychiatric emergency to
So there's similarities and differences. So the inpatient treatment center that does exist in the jail is LPS designated. So when a person is in there on a LPS hold, then and there's a Reese petition, they can be given medications. In a 5150 hold, and all holds do give the treatment team the ability to involuntarily provide medications in emergency situations. So if there's any sort of current threat, right, then any hold, a team can provide medications. There's this whole other side of things in the jail, which is largely related to the incompetent to stand trial group that for whom there are involuntary medication orders separate from LPS law. It's part of the penal code laws that allow for medications to be given for felony incompetent to stand trial individuals with the goal of restoring them to competence. And that's a whole nother issue. And then just this year, we got repassed because when they took the misdemeanor IST folks out of the pathway to be restored, which was overall absolutely the right move in terms of like what the nation needs to do and whatnot. But they also made it so that there was no ability to get an involuntary medication order for misdemeanor IST folks. And some of those folks are extremely ill, and they're so ill that they wouldn't be able to actually get into some of the community programs without treatment. So we were able to reinstitute the ability for the judge to put in an involuntary medication order with their misdemeanor IST order.
Real quick, do they do a Reese hearing in a jail setting?
They can,
They
yes.
can? Okay. Another question. This one wanted to talk, so.
Back and kind of walk us through that. And then secondly, in terms of linkage, is linkage those windows, or is there anything that extends beyond the doors of the jail?
Is it on? Okay. So we'll start with the windows. So there are the pharmacy window that I mentioned is inside the locked, custody facility. And in theory, with the assistance of LASD, every inmate who's released passes that window on their way out, is required to. There's the other, the exit window that Lisa spoke on is actually outside. So once you have been released and you are free. So not everyone wants to stop at that window. I think if you've been in jail for weeks or months and you get a taste of freedom, that may not be your first place that you may not want to stick around the jail, and that's obviously totally understandable. But that's where we have a lot of services that anyone who has not had the chance to have a fully formulated release plan, that's where we can kind of fill in some of those gaps and provide them with referrals or linkages to housing and mental health care, et cetera. But not everyone stops there, or not everyone chooses to stop there. That would be voluntary. And then there are also other Los Angeles County agencies like JCOD, Justice Care Opportunity Department or Division, who has a table outside in that area as well, and can also assist with linkages to the same services. And then, I'm sorry, what was the second part of your question?
In many cases, even under medication, some of the seriously mentally ill lack the cognition to navigate the mental health system. Some of them are conserved. Even if they're not conserved, they still have impairments. So releasing them from jail with a paper with referrals really is difficult for them to follow through with. So I'm just curious, is that basically the policy, or is there any other thing to kind of provide support for them?
Okay, that's a good question. So anyone with serious mental illness is, we are required. So like our P3s, for example, we would not release them with just a piece of paper. Like these are the people that our team that Lisa and I supervise is working every day to actually make a linkage to a facility. Just for example, like Tarzana Treatment Center, we would say, okay, they're not just released to this release area. They're actually, we have someone come and pick them up and transport them to this facility at the time of release. So there's an actual linkage being made. The people that are just getting the piece of paper, like the initial release plan with a list of resources, are those who haven't been evaluated by a mental health professional and have been deemed to be competent or stable enough to be able to navigate the system themselves, essentially.
And I can answer a little bit to this too, and I'm sure Joan can too. So one way to conceptualize what it means to be a P3 is that some people are quite vulnerable. They really can't be in the dorm setting. But another way of thinking about it is they're often gravely disabled outside of a situation where someone is not putting them into a place with a roof over their head, handing them clothes, and handing them food, right? And like literally caring for their personal safety, like those, and their medical care. Those are now as of January 1st, those are the 5 things that, are involved in what it means to be gravely disabled. So like outside of the jail, they might not be able to do those things for themselves. So when a person at the P3 level is released, like the order comes back from the judge, that person is evaluated by a mental health clinician or a psychiatrist, someone who can evaluate someone for a 5150 and decide whether or not they meet criteria. And if they meet criteria outside of the jail for a 5150, then they are transported. They are put on one and they are transported directly to a facility like Exodus Urgent Care or LE General, where they would on that 5150. Does that make sense? I think there's this large group of people in between who are not, I think, necessarily being a part of this program because they're also going to diversion programs. So people who are getting diverted into any of the ODR programs or some of those other programs, like they also are supposed to be getting like a pickup, and that gets to move them. But of course, there are lots of people who fall through. Oh, and people who are conserved. I mean, part of the conserved people, the problem isn't that they're being let out on the street. The problem is that they're staying in jail for months and months, conserved because they haven't found a place. So sadly, that is not the issue. The issue is that we can't find another place for them.
Barb?
Thank you so much. Barbara Wilson from North County. Thank you so much for putting this together. I wade through your acronyms, but I really very much appreciate it. I work a lot with families, and I am a member of NAMI myself. And 2 things that I hear over and over again that I just want to be clear on. Number 1, people getting released from jails at 2:00 in the morning, and they are from Lancaster, Palmdale, Santa Clarita. No phone that's charged because they've been incarcerated, no money, no cigarettes, they're just released. We have talked about this for at least 20 years, and I don't expect you to have a solution today. But I just want you to hear that this is a continuing problem. Even for people that live in Santa Clarita, their loved one gets released from Men's Central, and then they've got to figure out how to get back to North County. So if could be some kind of attention paid to this. And second question that I hear most from families is my loved one goes in and out of Twin Towers, in and out and in and out. why isn't there some way to get them on a conservatorship? And they talk to the psychiatrist and they talk to whoever is the clinician and they get hope. Oh, it's going to happen this time. And then they find out that they were transported to yet another open facility. And, in no time at all, they're using and dire consequences. So thank you.
I encourage you to talk to the public guardian about the issue of conservatorships. The public guardian is ultimately the team who is deciding whether or not that person should be placed on a conservatorship. They probably do not have the resources they need to conserve the people who really would truly benefit from at least a year of conservatorship, if not many years. But they also have different views from many of the people in this room about what it means, like what conservatorship should be. And that is where a lot of this issue comes from.
And as far as the 2 a.m., it's always been my understanding that's when the sheriff can do it, and that they can't hold anybody longer. Once their time is up legally, they have to be released. They can't. There is a new law that from several years back, I forget the name of it, where you can offer them 24 hours, I think. Can one of you describe that process and how that works?
Yeah, anyone in mental health who is released is offered to stay, but as you said, it's a legal problem to hold them against their will once they've been released.
So if somebody wants to wait till sunrise?
They're going to be discharged,
So these folks here can't answer that question because they're from the clinical side. And
okay.
That's a custody question, and there's nobody here from the sheriff's department to address it to.
Okay.
But you and I can talk about that. Yeah, you've been waiting a long time.
Yeah, I'm Edward Goldstein. I'm a health educator. Oh, thank you. I'm Edward Goldstein. I'm a health educator, physical therapist. And I notice there's social workers, there's psychiatrists, there's psychologists. I'm a health educator that specializes in forgiveness and write books and lecture on the healing power of forgiveness. It's been my experience that dealing with people with anxiety or minor issues, the core base has to do with the fact of the inability to understand or forgive themselves or others of anger, guilt, shame, and blame. The process I use is non-triggering, and it's the definition of terms and the language that has to do with the logic. I'm wondering why, or if there are any health educators in your system that could actually do some work on levels that the psychologists and psychiatrists aren't addressing. As a physical therapist, I will also incorporate certain breathing exercises, relaxation, and mindfulness. And all that has worked with people that have gone for dozens of years of help and got it within 1 or 2 sessions working with me.
You ever been to the jail? I'm not being facetious.
No, I know that.
I mean, there's
a lot of chaos.
Utopian concept, not in the community, but in the jail setting. It's asking like the one thing that I think would go along with your question a little bit is the groups that are held. Now, I know there's been like substance use disorder groups and there's anger management groups, and families always say to me all the time, well, he's not getting therapy. Well, you're not going to get therapy in the jail, but are there any kind of group sessions now? Because in my day, when I was involved with the jail, there weren't.
Group work.
Yeah, there are groups offered for P3s for the high observation. We would love to offer group for all mental health, but that's where we're able to do it.
Okay. Two more. She's been waiting a very long time, and Debbie, I know you want to go too. So, that's probably all the time we have. And this has got to be fast. We got 2 minutes, so I need to give you 1 minute.
Okay. My name is Glenda McCauley. I work for a mental health agency called Victor Community Support Services. And we have a program called the Enhanced Care Management Program. It's a non-clinical case management program where we support a very wide, diverse population of individuals with linkage to resources. And one of the biggest populations that we're trying to get our foot into is the justice involved. So how open would you all be to getting maybe a card and a flyer for me after this? Yes, that was it.
I see affirmation. Yeah.
Thank you so much. Thank you.
Debbie, go ahead.
Acute danger. What does it take to get them? When they're in jail, they have anosognosia, they don't have insight. At what point of degree of illness will they be treated against their will or against their understanding of what they need?
If they are not in the jail setting, if they can, when things are given to them, they are not gravely disabled and they're not a danger to themselves, so that they wouldn't need one of the precious beds that are in the hospital beds that are there, then there is no way to involuntarily medicate them. So the only ways to involuntarily medicate someone are either through LPS law or through currently the incompetent to stand trial laws. So if that person is found incompetent to stand trial, an involuntary medication order can be written. There's no other way for them to be administered medications involuntarily.
That's a revolving door. They're going to just keep coming back.
It sure is.
It's
yes.
the law. Are we done? Oh, I'm being told we're out of time. Let's thank our guests, please, our panelists. Great job. Great questions. Thank you for coming and attending, and enjoy the rest of the conference. And thank you all of you.